thank you very much, and thank you to the ALS Association for sponsoring this event and for all of the people listening to this online. My goal is to provide a brief overview for you, and then our experts will go into much more depth about these topics coming up shortly. So to talk a little bit about multidisciplinary care for patients with ALS and FTD, I'd like to first talk about the clinical features of the disease, which many of you, of course, are aware of these features, and know that not every ALS patient experiences every one of these symptoms, but we need a certain number of these symptoms in order to diagnose the disease. And so patients have damage to both the upper and lower motor neurons. Damage to the upper motor neurons tends to cause slow speech, brisk gag and jaw jerk, brisk limb reflexes, and spasticity. Lower motor neuron findings include atrophy, fasciculations, and weakness. And when patients have this combination of findings and neuroimaging is negative, laboratory testing is negative, we conclude that this is the diagnosis. So it's a diagnosis of exclusion, which makes it hard to diagnose. And that's why the American Academy of Neurology does recommend that patients be seen in a certified ALS center in order to really make sure that this is the diagnosis. After making a diagnosis and breaking the news, we start to think about what can we do to treat the patient. And currently we have one approved drug from the FDA, Riluzole, to slow the disease process. But we have many, many treatments that help with managing the symptoms of the disease. Managing respiratory problems, managing difficulty swallowing, preventing malnutrition, and then treating many symptoms that reduce quality of life, such as excess saliva, easy laughing and crying, or pseudobulbar affect, spasticity or stiffness, cramps. We want to maintain mobility as best we can. And this is achieved through multidisciplinary care, and then towards the end stage is palliative care. And there are guidelines from the American Academy of Neurology that direct what types of treatments are appropriate for ALS in all of these different categories. And so I'll go through these very briefly, and then our experts will be going into much more detail. So first of all, as far as nutrition, I'll just briefly talk about this because David will be going into much more detail. Causes of poor nutrition include swallowing difficulty, arm weakness, making it difficult to bring the food to the mouth, shortness of breath, and increased energy expenditure, which can burn more calories. Solutions can include better breathing support, eating aids, a high-calorie, high-protein diet, food consistency modifications, and eventually use of a feeding tube in some cases. As far as breathing, causes can be diaphragm weakness, chest muscle weakness, and increased energy expenditure. Solutions include breath stacking, non-invasive positive pressure ventilation, diaphragm stimulation, and invasive ventilation. And again, we'll get into this in much more detail with Lee's talk. As far as how frequent the different symptoms are in ALS, muscle cramps are the most frequent feature, followed by fasciculations, stiffness, depression, fatigue, constipation, difficulty sleeping, sialorrhea or excess saliva, anxiety, dry mouth, thick phlegm or thick secretions, labile affect or easy laughing and crying, urinary urgency, and laryngospasm where the throat tightens. So these are all symptoms that patients with ALS have, and they're symptoms that we can often do something about. For cramps, one of the most common symptoms, we can recommend a massage, hot baths, stretching. If patients desire medications, there are Tegretol and baclofen are often used. Mexiletine is currently being tested in a clinical trial at UC Davis, and that's a trial that any patient in California has access to because the trial is being done with telemedicine. So it's rather innovative, and if any of you are interested in participating in that trial, Bjorn Oscarsson at UC Davis is the person doing that trial. Quinine sulfate is still available in Canada, and there are low doses in tonic water, and some patients say that drinking tonic water at night can help with their cramps. As far as spasticity, there's a balance between being too stiff and too loose. If you treat with too high of a dose of medication, it can actually make you feel weaker because you're losing that spasticity that's giving you some control of your gait. but too much. But if you're too stiff, then the gait can be very slow, and that can be cause difficulties as well. So we typically start with baclofen and then often add other medications such as diazepam or Valium, dantrolene, memantine, and tizanidine. When these medications fail, or if people have difficulty tolerating them, we can consider using a baclofen pump where the medication is given directly into the spinal fluid, and then that helps relieve the stiffness without causing the side effects that the oral medications can do. And we have a program at UCSF to do that. Botox can also be used for spasticity, and that can sometimes be beneficial. As far as excess saliva, we often start treating with the milder medications and then proceed to the stronger medications. So amitriptyline or Elavil is a good one to start with and also helps with sleep. Glycopyrrolate or Robenol is a pill that you can take as needed for saliva. Atropine drops are helpful, particularly if people are having trouble swallowing. The scopolamine patch is a patch that can be put on the skin and can dry up saliva. And then sometimes when these things fail, or if people have a lot of side effects from the medication, it can cause quite a bit of constipation. Radiation therapy is sometimes used, or more often Botox treatment. Botox is given to the salivary glands to paralyze the muscle, which allows less salivary production. And the problem isn't that ALS is causing more saliva, it's that you're having more difficulty swallowing it, and so more saliva is remaining in your mouth. For thick saliva, which is often a problem when you start to dry up saliva, we use Robitussin, just over-the-counter plain Robitussin or Robitussin DM is quite effective at loosening up the saliva. Some people like Mucinex, which is also another form of guaifenesin. Increasing fluids helps, and then sometimes using a cough assisted machine or suction machine to help get rid of those secretions helps as well. Pseudobulbar affect, or easy laughing and crying, is a problem that affects more than half of ALS patients, and it can be hard to diagnose because it can be confused with depression or confused with just appropriately adjusting to the disease. And so, but once a diagnosis is made, it is typically managed initially with amitriptyline or Elavil. If that fails, then the serotonin reuptake inhibitors can often have a mild effect on symptoms, but the best drug is a relatively new drug, just a couple years old, called Nuedexta, which is a combination of dextromethorphan and quinidine. And most insurance companies require you to try some of the other drugs first that are cheaper before going to Nuedexta. But Nuedexta is really quite effective, and these drugs don't typically have too many side effects. As far as urinary urgency, we recommend treatment typically with anticholinergics such as Detrol or Vesicare. Again, these do cause constipation, so your diet often has to be adjusted to help with that constipation if you're on these medications, but it definitely can help sleep through the night without having to get up and go to the bathroom. If these medications don't fail or it's a more significant problem, condom catheters are often helpful. And then once in a while, patients will choose to have a suprapubic catheter put in surgically, and then obviously you wouldn't need to go to the bathroom in that situation. There are male and female urinals available that can be used as well. As far as depression, it's really important to make sure there's not something else going on, like a respiratory problem or poor nutrition. Poor sleep can also make someone appear to have depression. We often recommend referral to a counselor to talk through appropriately the feelings that can come up as you're working through the disease process. But sometimes antidepressants are needed as well, and there's many, many good choices of antidepressants that are helpful for this problem. As far as sleep, most ALS sleep problems are mechanical, and causes can be lack of appropriate breathing support at night, or difficulty positioning during the night for comfort. When we hear someone having trouble sleeping, we often will order a nocturnal oximetry, which is a non-invasive test that can be done in the home to look to see if there's any problems with getting enough oxygen at night. And then as far as difficulty positioning, trying to strategize and figure out ways in which it's possible to help someone turn at night so that they can be in different positions. It's not normal for us to lie completely still all night. If a sleep aid is still needed after mechanical problems are worked out, then we like to start treatments with really mild agents. Even over-the-counter things can be helpful, like Benadryl or melatonin. There's some herbal sleep aids as well. And then there are sedating antidepressants that are often helpful, like Elavil or Remeron. Remeron also helps stimulate the appetite, so that's a medicine we often think about using if someone's having trouble with their appetite and trouble sleeping. And then lastly, we also think about benzodiazepines, things like Ativan or Valium. They're more sedating, and sometimes people feel groggy the next day, but at low doses, they usually work pretty well to help with sleep. I've mentioned constipation quite a bit, and I'm sure David will go into this in more detail in his talk, but certainly increasing fluids is helpful, increasing fiber, considering stool softeners, and then considering, in more significant cases, prescription medications such as lactulose to help keep things moving. As far as weakness, Andrew is going to be going into this in more detail in his talk and also talking about exercise, but for weakness, while we can't reverse weakness yet with this disease, hopefully we will be able to in the future, perhaps with stem cell therapy, and we'll hear more about that later this afternoon. But for now, we try to optimize the home and work environments. We try to anticipate equipment needs. Even if you think you don't need something, it's a good idea to go ahead and get it in preparation, because sometimes things can take a long time. And so you want to have something when you need it. We sometimes recommend driving assessments for safety when people are interested in continued driving and they are having some weakness in their arms and legs. And then, as I mentioned, Andrew will go into a lot more detail about exercise and the safety of that. You can have a free work assessment with AT Network to optimize your work environment, and also home assessments with home safety evaluations are very helpful. There are specialty contractors for home remodeling who specialize in dealing with patients with disabilities and knowing how to remodel bathrooms and staircases appropriately. And then lastly, hospice can be helpful too in providing equipment that can make it safe in the home. There have been so many advances in equipment, things like flexible ankle-foot orthotics, lighter, sturdier walkers, canes, and crutches, manual wheelchairs that have the tilt and recline features that formerly power wheelchairs used to have. And there are even electric wheelchairs that weigh just 14 pounds that you can fold and put in your trunk. There are stair lifts and stair climbers, portable ramps and rail system, and then specialized beds that can even turn patients. So these advances have made it possible for patients to be more comfortable. I think I'll skip this slide because Andrew will be talking about exercise and how to do that with ALS. But there was one study that I do want to just briefly point out, and that is that resistance exercise is beneficial in ALS. There was a study with 27 patients looking at a trial of daily stretching and resistant exercise 3 times a week. And after 6 months, quality of life was better, the ALS functional rating scale was improved, and muscle strength declined more slowly. So it is important to incorporate this. And then just to say a word about very end-of-life issues, it's important to talk about end-of-life issues throughout the disease process. We recommend people enroll in hospice as soon as they're eligible to be able to take advantage of all of their services. We recommend people utilize home care frequently as needed as their disease process changes, particularly if they're not hospice eligible yet. And then it's very important to continue to follow in an ALS multidisciplinary clinic, even when in hospice, because we're able to provide recommendations that will help not only your quantity of life, but quality of life as well. So in the next few minutes, I'm just going to say a word about the cognitive and behavioral abnormalities that can be found in ALS. Typically, people think of ALS as a motor process, but sometimes patients can have cognitive and behavioral changes. And this slide just summarizes that around 25 to 50% of patients, depending on the study, can have some type of changes. It can be very minor, like just some word-finding trouble, or it can be more significant with significant personality changes. And this slide just shows what we found at our institution, that around half of patients had no problems at all, and then about a quarter met criteria for frontotemporal dementia in this particular study, and then a quarter had more subtle abnormalities. And then this just shows that there is a anatomical correlate to these changes. It's not just adjusting to the disease or something else. There is a biological explanation for what's going on. And in this slide, the important thing to focus on is the red. And the red, there's more red in slide A as compared to slide B. And patients shown in slide A were patients that did have cognitive and behavioral changes, and in B, patients did not have those changes. But even in patients that didn't have changes, there were still some abnormalities in regions of the brain that are involved with executive functioning. There's also pathology that supports this, in that when patients die from the disease and on autopsy, there are abnormalities found not only in the motor system, but also in the frontal and temporal lobes. And there was a protein that was found to be in both ALS, as well as in patients with frontotemporal dementia, and in patients who had the overlap symptoms. You're going to hear more about this later, but there was a gene found in 2011, C9orf72, which is responsible for most familial ALS cases and also some sporadic ALS cases. And that's a gene that can cause either ALS, FTD, or both. And these are just some of the typical behaviors that you may see in patients with FTD: apathy, disinhibition, poor judgment, easy frustrations, being quick to anger, lack of insight, and language difficulty. And some of these, of course, can be appropriate coping mechanisms with the disease, but I think we used to think of these with these older descriptions as saying that was always the case. And there are situations where it's more than that, and it is, there is a biological cause for some of these behaviors. It's very important to rule out mimics. There's many things that can mimic these symptoms in this disease. And I just want to say a word about this clinical significance. We did a study looking at survival, and we found that for patients who had both ALS and frontotemporal dementia, patients who had more serious cognitive and behavioral changes, that their survival was about a year shorter than patients who had ALS alone. And we found that one thing that was going on in that situation is that compliance with treatment recommendations was much less. And so patients just didn't, well, I'll show this on this next slide here. Patients used BiPAP and wanted a PEG tube much less than patients who had ALS without any cognitive or behavioral changes. And so the reason it's important to look for it, and for those of you who've come to our clinic, we're doing a lot of research and screening for these problems, because patients do have a reduced survival rate. Compliance is an issue, and we have to think about ways to help with this. It can cause caregivers quite a bit of distress. There can be poor safety awareness, where patients fall and will often choke on food because of not taking small enough bites. There can be an inability to manage important decisions, and there can be implications for stem cell therapy, where we're treating the weakness but not necessarily treating the cognitive changes. And so to summarize my talk, there are medications available to treat many of the symptoms of ALS. Equipment advances enable patients to be more independent than ever. Multidisciplinary clinics improve the quality of life for ALS patients and have been shown to prolong survival. So just attending a multidisciplinary clinic prolongs survival. And then it's important to be aware of the cognitive and behavioral impairments that impact both survival and management. And I'd like to just point out all the members of the Multidisciplinary ALS team that all work together to help manage this disease. So thank you. And so now we can open up to questions, both from the floor and also from people who are online. But maybe we'll start from people on the floor, if there are any questions. It was an overview, so it went kind of fast, but.
Just a mechanical question. Are the slides available afterwards that we can look at?
Sure. Yeah, I can provide them to the ALS Association.
Great,
Mhm.
thank you.
Is this the time to ask about stem cell? My husband tried it once. Should we try it again? It's been a year.
Yeah. This afternoon, there are going to be more detailed discussions about stem cell therapy, but my recommendation, would you know if it was done in the U.S. or was it done outside the U.S.?
No, it was the U.S.
In the U.S., okay. I would probably
Cupertino.
talk to the people who did because it can vary so much depending on what was done and how long they predict the stem cells to survive. So I think I would talk to the people who did the procedure and ask them their recommendation. But we definitely recommend, if you're going to do stem cell therapy, to do it in the U.S. Through a trial that's on clinicaltrials.gov. That's a good website to go to, www.clinicaltrials.gov. It lists all the approved trials in the United States, and so I think it's a good resource to check for trials in your area. Any other questions?
You said it's good, important. Is that there? I can speak up.
It usually comes on after you start talking for a few minutes.
There you go. That one is. Reimbursement for hospices, if you're Medicare, and it would be 100%. But usually outside of the hospice services, attending clinic would not be covered, or how is that covered?
Hospice has always covered it.
Oh, they have.
Yes. Patients have not had to pay anything. I think the reason they justify it is because hospice has always really benefited from our recommendations, and they see how much it benefits the patient. And so, in fact, when a patient's in hospice, if we haven't scheduled an appointment for the patient, the hospice agency will typically call and say, we need to get so-and-so in for an appointment because things have changed and we would like to hear your recommendations. So I don't know where the money's coming from, but it's not coming out of the patient's pocket. Yes.
I have a question about hospice. When you think you would be qualified for that?
There are Medicare guidelines for when someone's qualified, and your breathing capacity, your forced vital capacity, needs to be less than 30% of what would be predicted, or you need to have rapidly progressive ALS. And so as long as you have one of those two criteria, and we always talk to patients as soon as they reach that 30% mark about that as an option, then you would qualify. Or if you have rapidly progressive disease, even if your breathing numbers are higher, we can justify hospice in that situation. And of course, you can always go off hospice if it's not the right thing for you. But they provide a lot of help, aides that come in the home and help with bathing, and a nurse that checks in once a week. And often have physical therapy or occupational therapy, so it's really a nice service.
Yes, I'm concerned about wearing my caregiver out. What can I do to help her?
That's a really good question and a really good concern, and I think that the ALS Association care managers can help a lot because they go into the home and they can help talk with you and think about potential solutions. But it's one of those things that unfortunately insurance doesn't cover in terms of paying for caregivers, and so a lot of times it involves thinking about how to be creative with finances to try to come up with the money to be able to hire a caregiver. But I find that just talking with the ALS Association care manager often helps because they know of resources usually in your local community that may be helpful. Yes?
Yes. Is this going to go?
And then we have a second question there after that if you want to pass your microphone. Or if there's, I don't know if there's more than one microphone.
Could you describe the parameters or the criteria for rapidly progressing ALS? And forgive us, we were a little bit late, so I don't know if you covered it or not.
No, I didn't. That's a good question. So it is a clinical judgment. And so I think that when someone seems to be changing month by month as opposed to every few months, then that would be someone that is probably more rapidly progressive. But it's something that the neurologist and the clinical team bases on a variety of factors: how quickly breathing's declining, how quickly strength's declining. So a few things are going into that. And then the woman in the black had a question.
Sorry, it's not working right now. The woman in the black doesn't need it.
because within that community, people bond and people are with each other, and it's also a way, not just hands-on that you'll need, but also a way to connect emotionally and to get the support from each other.
Thank you. Those are great suggestions. And if people didn't hear it because there wasn't a microphone, the suggestion was to go to caregiver support groups, to go to ALS support groups and connect with other families and get ideas. And we have, I think, a couple more questions. And then are there any online questions, Jenica? Okay. However you want me to do those.
The other thing is, if you're a caregiver, there's the National Caregivers Association, which is online. They're there 24 hours a day to help you.
That's a great resource. That was nationalcaregiversalliance.com, and there's someone available 24 hours to talk to, as well as a lot of good handouts and resources as well. Okay. Should I take the on? Oh, sorry. Go ahead. No, the question is, are there differences between the ALS clinics? As long as you're going to a clinic that is certified by the ALS Association, you can be assured that that clinic has been fully evaluated by outsiders who are specialists in ALS. They've been found to have all of the right clinical components, and so it doesn't matter where you go as long as it is an ALS Association certified center. And you can find a list of those on the national website. And more are being certified all the time. But right now, there are 2 in San Francisco. There's 1 certified in San Francisco, 1 certified in LA, and 1 about to be certified in San Diego. And there may be more that I'm not aware of, but those are the latest ones I know of that are certified.
Great. I think we have time for one more question before we move on.
And then Jenica said there were 2 online questions as well.
We have a question from the internet. When should a family facing ALS consider is the right time to start BiPAP?
So the right time to start BiPAP is a decision that will be discussed in the clinic, and I believe Lee will be going into that in her talk, so I'm going to defer to her for that question. And was there another online question?
We have another question from the internet that talks about nutrition. Do you recommend that people who are having problems with chewing but not having problems with swallowing consider a nutritional intervention?
I think that's a very good question. I mean, and David is going to be going into that in more detail, so I'll just briefly answer that you may need to change your food consistency. The things that are hard to chew, obviously, are going to be hard to get down safely. But the decision about when to proceed to the PEG tube would again be something that you'd probably have to discuss in clinic with the team because there'd be many factors involved.
Great. One more question.
Yes.
Are there any updates or development with the UCSF Fresno clinic?
Yes, so the UCSF Fresno clinic, there's an ALS and an MDA clinic there, and the physician recently left there. And so what I have been doing is I have been doing a monthly telemedicine clinic with their whole multidisciplinary team. So patients come there, they see the whole multidisciplinary team, they see me via video, and until recently, patients were required to at least once come to UCSF for a new patient visit before being seen in that clinic, but given the clinical need of the patients, that has now changed. And so as of February, I am allowed to see patients in Fresno that have never traveled to San Francisco. So that's how we're managing it on a month-by-month basis. But the UCSF is very aggressively trying to recruit a neuromuscular faculty person to come to UCSF Fresno. So hopefully that is something that will be solved hopefully by summer or fall. But I'll be doing the telemedicine as long as is needed to at least help take care of those patients. And then, of course, if a patient would like to come to San Francisco, both California Pacific Medical Center and our center are very happy to see them in our multidisciplinary clinics here. And I've spoken to CPMC about that, and they're very willing to do that. Okay, so we're ready to go on to the next part. So I'd like to introduce our clinical panel, and I think all of the questions have been great, and our panel will likely go into more detail about many of these. topics. We have Amy Roman, who will be from California Pacific Medical Center, who will be speaking on the 7 components of a highly effective communication system. And next to her is Li Gian, who is also from California Pacific Medical Center, and she will be speaking on the 7 best ways to maintain lung health in ALS. Andrew Louie, our physical therapist from UCSF, will be giving an update on exercise for patients with ALS, the why, when, and how. And then David Bezio, who's a nutritionist who works both at California Pacific Medical Center and UCSF, will be speaking about A+ nutrition for ALS. And so each person will speak for 15 minutes, and then at the end of it, we'll have a Q&A for all of them. So save up your questions for then. Thank you.